right. Well, good afternoon, everyone, and welcome to the MMI Conference. So I'm Al-Mallah. I'm the Director of Cardiac PET at Houston Methodist, and today we're going to talk to you about cardiovascular PET. So this is the physics/tracer kind of talk, and then during the year we'll dig more into each of the applications. For I know some of the fellows are taking the nuclear board this year. Some of them are not in the room yet, but a lot of what I will say is usually highly tested information. All right, so what about cardiac PET? So PET stands for positron emission tomography, and we're going to go over first the anatomy of the scanner. So this is not anatomy of the human body, but more of the scanner itself, what's inside the scanner. And then we will go ahead and dig deeper into what is made inside. All right, so many of you are familiar with SPECT scanners. So SPECT or SPECT CT scanners, the way we put the patient in there, so many of you see what we have in Fondren 9 on our scanner, where we have a scanner, it has two heads, and then it rotates around the patient, usually around 235 degrees, and it covers the patient tomographically in that kind of approach. So this is what we usually get from a SPECT scanner. So the main concept of nuclear compared to CT, for example, both of them use radiation, but in nuclear we inject the radioactivity in the patient. It will go to different parts of the body. Some of them we try to direct them to the heart, and then from there we do imaging focus at the heart and try to see where that radio tracer is. So the source of radiation at the time of imaging is really the patient, because we injected that amount of radioactivity within the patient. And the way we image them and the tracer will determine the type of imaging we want to do. So with SPECT imaging, we inject usually technetium, and we use a SPECT system that has usually sodium iodide crystal or CZT crystal, and try to image the patient. Usually the sodium iodide crystal, as I mentioned, rotate around the patient, as many of you have seen in their nuclear rotation. What about PET? How is first of all, the anatomy of the machine? This is a machine that we have in our research institute, but we also have in the outpatient center. This is another PET system from another vendor, so all of them technically from outside look the same. If you start to take out all these nice covers, and this is how the system looks from inside. So it's called a PET CT system. It's a hybrid system. What does that mean? It has a PET scanner and a CT scanner. A CT scanner is exactly like any other CT scanner that you know about. So it's very similar to the CT scanner that you will hear about, I think, in a couple weeks. And it's usually can be attached to either anywhere from 8 slice to 64 slice or higher CTs. Now we're going to today focus on the PET part. So if I zoom on this kind of CT, now you see these different rows that you see here. Let me see if I can move the mouse. Yeah. So these are different rows of detectors. So these are the detectors. So compared to SPECT, where the SPECT head is rotating around the patient, now we have a full circle, a full ring of detectors around the patient that is in there. So if I zoom around it, you see now how they are. So under each of these is a unit of detectors. So it's very important. For example, the technologists, when they come every day, they have to check that every unit is working fine. So there are certain tests that they have to do on a daily basis to ensure that these units are working fine and they are capturing what they are. So the main concept, why do we need a full ring of detectors compared to a 2 detector that rotate around the patient in CT? Well, the main thing we need that is because of the physics of the radio tracer. So when we inject a radio tracer for PET, what happens is that annihilate initially. The positron will move depending on the energy that you see here, and then it annihilate 2 electrons. So while in SPECT it's only 1 photon going to the detector, now you have 2 photons that are going against each other, and one is going to hit on one end, the other is going to be 180 degrees. So one of the ways we image these is that we need to ensure that we have detectors on both sides of the 180 degree so we know where it is coming from. So that's kind of the main concept why we need to have a full ring of detectors in PET compared to what we have in there. So what do we see in these units? So I showed you these kind of covers that you have in this unit. So if you start peeling them off and start to see what's underneath it, then you will see a few things. You'll see the crystals, and then you will see the photomultiplier tube. I don't know if the mouse is coming. Yeah. So you see the photomultiplier tube, and then they are all put out in ring. So these are like another picture. So these are the detectors. They are probably the most expensive and most delicate part of the PET scanner. And they are the detectors. Usually they can be lutetium based or BGO based, and these are the current 2 that are available in the market. And then they are attached to a photomultiplier tube, and then there is the electronics behind it. And under each one of these there is this whole unit. So under each one that I showed you before, that peel, under it there is a full unit that has detectors, photomultiplier tube, and then there is the electronics that are in there. And these are the different types of detectors that are available. Most of the ones that we are using in PET are the BGO or the lutetium based. So the one that we have here is the LSO based, and they give you all that information. So what happens when these 2 photons come and hit the detector? What do they emit? They emit light. So these detectors will give a very faint light. Then it goes inside the photomultiplier tube and get amplified. So it's the name, photomultiplier tube. So that detector, it's going to multiply it multiple times, and then it will go through electronics, and it will be amplified and processed. Now, based on the time that you hit these detectors, based on the time, it will say, well, this happened, I got a photon here and a photon here within nanoseconds. So this is how sensitive these are. It has to be within nanoseconds. Then it will say, well, these are 2 real photons. I'm going to assign it a point in the middle where it came from. So this is how the unit is. So the other aspect that you need to know about is that in the past, we used to be able to align exactly where that photon came. There is 2D systems, so we put septae in front of the detector. So we get only the ones that are coming and hitting the detector on a straight line. So if something is coming scatter like this, or any other way, then it's not going to come and we will not detect it. Now, with the advent of new electronics, we are able to correct for that, and we know how much is scatter and how much is through. So now most systems in the market are 3D. They are more sensitive, but at the same time, they could detect more scatter. So they are very helpful to detect signal if that is very low, but at the same time you have to have good electronics and good algorithms so you can throw away the scatter and keep the true signal that's coming from the heart. Now, a big advent that happened in cardiac imaging in general, but in PET, is that many years ago, like I would say about 7 or 8 years ago, this photomultiplier technology became obsolete, and now we moved all of these that you see here, this whole photomultiplier, now it's just condensed into a piece of electronics. It's more efficient, and it can detect that light, and it enhances the sensitivity very much. So now when you go in the market to buy a PET scanner, there are some that are still analogs, but if you want a top-notch program, then you can go and ask for the digital PET, which has much higher sensitivity, and it allows you to detect even the image quality is very different, and especially if this makes a huge difference on oncology and others, even if you inject lower dose, then you are able to get diagnostic image quality. So for example, just to put things in perspective, on a regular 2D photomultiplier tube system, you need probably to inject 50 to 60 millicuries of rubidium. On this kind of system, we inject 10 to 20 millicuries. So we trashed our doses by one-third. So we are able to lower the radiation exposure and get even better image quality even with that amount of radiation. So it allows us to lower the doses and lower imaging time for some of these patients. So these are the digital PMTs. They started with one vendor, but obviously, as everything, all vendors now have it, and it's widely available, and the prices obviously are coming down significantly for these. Now, the biggest concept, as I said in PET, is that instead of our photons coming one way and we image them like we do in SPECT, now we're talking about two photons that are going at a 511 keV. So in SPECT, if you're using technetium, it's about 140 keV. I see some of the fellows smiling because I keep asking them about these. So in SPECT, you're imaging at 140 keV. Now you're going almost 5 times that. You're imaging at 511 keV. So, and then you're emitting two photons, so you're detecting two photons at the same time. So that's one of the tested areas where they will ask you what's one of the differences between SPECT and PET. It's the energy of the photon. So you're not only emitting two photons, but you're emitting them at 180 degrees, and they are much higher. So we can detect two photons in multiple ways at 180 degrees. So one of them is what you see here is a true event. So when you see here a true event, if there happen two photons hitting the two rings at 180 degrees, the computer will say, this is a true event, and I'm going to record the point. But something to keep in mind that there are multiple other ways that this could happen. So one of them is a true event, but others, they could happen as other examples I'm showing you here, the scatter or the randoms, because when you inject the activity, there are so many photons running around and coming out from different parts of the body, because the rubidium or the ammonia or any other tracer are at different parts. So there is a chance that two photons hit randomly at 180 degrees and make you think as if that there is a true event. But there are some even nanosecond differences that the technology now is able to differentiate them. So again, if some of you are in the market to buy a scanner, one thing, this is called the time of flight. So companies or different vendors will compete among each other. I have the best system because my time of flight is 400 picosecond or 400 or 480. So it's going down to these kind of differences. The electronics are so sensitive to detect these, especially with the digital PET, that you are able to detect them faster. Again, this is the energy of what we're focusing on, because some of these randoms and scatters will have lower energy. So when you image, that's a concept like you do in SPECT also. You tell the electronics and computer to look only within a certain image energy window. So usually, again, one of the tested points is that usually about 10% on each side of the spectrum. So if you're doing, for example, SPECT imaging, you tell it 140 plus or minus 10%. If you're doing, because most of them are going to fall within the peak, but some of them are going to be on both edges. So for PET, for example, we can put it at 511, but then we can try to image within 5 to 10% in there. Now, another major difference between PET and SPECT is the issue of attenuation correction. Attenuation correction on SPECT is a luxury. So if we have it, it's great. We advocate for it. We have to do it. It's great. It makes the job of everyone easier. We become more certain about reading it. In PET, you cannot read a PET scan unless it's attenuation corrected. And why is that? One of the reasons, there are many physics reasons, and I don't want to bore you with all the physics, but one of it, I told you there are two photons, right? So one photon could be coming from one very anterior part of the heart, let's say the RV, and it will just need to travel tiny bit in the body and then in the air. The other one has to go all through your body, all the way to the back, and then go in the air, go through the table, and hit the detector on the other side. So one of the aspects is that while each one of them are going to travel different distances through different tissues, so they may not be, while they're contributing to the same image, each one of them became attenuated at a different time. So some of the ways to account for that is to look for attenuation correction. So you cannot read non-attenuation corrected images. So there is only one nuance in PET that I'm not going to go over today, that we look at non-attenuation corrected images. So in general, we only look at attenuation corrected. But in the process, if you talk to the techs, they generate these non-attenuation correction, but we label them here as do not send. So when you look at them, the techs know that they don't need to send them from the machine. They look at them, they correct them. The only time we look at these are when we're doing infection imaging or FDG imaging, and we're looking at something that has metal. So our dense calcification, that's the only time. But for perfusion imaging, it is a must. Your PET images are always attenuation corrected. Full stop. This is non-negotiable. You're not going to look at non-attenuation corrected images. So how do we do attenuation correction? There are three ways. The old way was before the advent of PET-CT. It was more on the PET system. So there was a PET, and then in front of it, there was a radioactive source that while you're doing the PET, the patient was getting another radiation from a source that was rotating around the patient. And then, so the patient is getting irradiated twice, one from inside and one from that source. And then they create MU maps for these. Luckily, these systems are becoming, so there are no new systems in the market for these, and now if you go to buy a new one, there's only PET-CT. There are some refurbished systems still in the market and they are being used, but no new systems like this. So within your career, you'll see these systems kind of vanish. Now the second one is the CT. So we do a CT for attenuation correction. That's one of the reasons we have a PET-CT, so we have a full CT. The CT for attenuation correction, as I asked you many times when we are reading, is a usually free breathing or end expiration, very low dose radiation. So you're talking about a DLP of 20 to 25 at maximum. One of the quality checks that we do in the lab is to look at the DLP for the CT attenuation correction. And because you only need to know what type of tissue these photons are passing through. So I want to know how much lung, how much bone, how much soft tissue. And to achieve that, I need a very noisy set of images. I do not need a good dedicated system or a good dedicated CT that can do that. And then the third one is MRI. So in the market, there are few PET MRI systems, and you can create the same concept with MRI. So you can generate a mu map for attenuation correction with MRI. They are not usually used in cardiology. They are primarily used for brain imaging and cancer imaging, and you can use the MRI for attenuation correction. So how does it work? So we acquire a PET image and we acquire a CT image, two separate acquisitions while the patient is on the same table. We assume that the patient didn't move, which we hope. The CT takes about 5 seconds to acquire. The PET is about 7 to 8 minutes, depending on your acquisition. We hope the patient didn't move, and then we take these two images and superimpose them on each other. So obviously, whenever you have two sets of images that you're superimposing on each other, you always run the risk that the patient moves in between, and whatever you superimposed didn't work that well. So you can potentially run some artifacts. And when this started, so there were like these PET CT systems started to come in about 2007, 2005 era, and they became more used in the early 2000s. And there were publications saying that misregistration, which means that these two do not align well, so the patient moved in between. They did not, the heart is not where it's supposed to be, because you have two images and you're just putting them on each other. So there were some publications saying this could happen in 1/3, and initially when this used to happen, there is no other way other than repeating the images. Now we have software tool where we can go back and just change it, but it has to happen on the machine. So when you do it, you cannot just work on the software and do that. You have to go back to the machine, talk to the techs, and tell them, I want you to re-register these. So there are tools to do that, but misregistration is one of the potential artifacts, correctable artifacts that you do not want to see on your studies. So if the patient moved, it's your duty to go back and co-register. So here's one example where you see an anterolateral defect, as you see on the images. Let me see if I can move the mouse there. So you see this area where it's not a full donut, so there is a defect there. And this is only because the anterolateral wall is overlaid by the lung. So technically, it's not because there is a defect, because when I go back and fix it, now it looks normal. So this was purely induced by the fact that I'm correcting that anterolateral wall to the segment that is in the anterolateral, as if it was the lung, when in reality it was not the lung. So it's a pure artifact induced by post-processing. And it's very important to recognize it and correct it. So we do not want to have false positives because of this. And then finally, the final differences between PET and SPECT. So the in PET we have 511 kV, as we mentioned, and SPECT is 140 kV. We acquire in list mode nowadays in PET, but we have the ability on some SPECT systems to acquire in list mode, and I'll talk about how do we do that and later on. So images in nuclear all depends on counts, how much activity I was able to image. So PET images, especially the digital ones, are very rich in counts. We have 3 million or higher counts. While in SPECT, because of the lower energy and the lower time, so your imaging in each position, your images are 500 to 300 K counts. So technically you can tell me, well, I can image for an hour and then get more counts. Yes, you can do that, but at the same time, it's doubling the imaging time to get a little bit more count, which may not be very feasible. And spatial resolution is much better with PET, especially the digital PET. You're talking about 2 to 3 millimeters, especially if you have a good tracer with good positron range. While with SPECT, we're talking about almost 1 centimeter. The newer systems, the CZT systems, are better in spatial resolution. They're down to like 2.5 to, they're like a little bit less. All right, any questions about the system itself? Now we're going to talk about the radio tracer that we give the patients. Any question about the system itself before we move on? You're just hungry, you're here? All right, we'll work so you can catch your food. All right, so the radio tracer is very different, obviously. I cannot use the same radio tracer because I want a radio tracer that's 511 kV for PET, while the radio tracers for SPECT are 140 kV. And the way they are generated are different. Most PET radio tracers are generated from cyclotrons. There is only one that can be generated from a generator, which is rubidium, while SPECT radio tracers come mostly from generator. And the resolution is obviously very different, much better with PET compared to SPECT. The half-lives is very different, but in general, the SPECT half-life, the SPECT radio tracers half-lives is usually much longer compared to PET. So even though we're injecting sometimes more radioactivity and we're injecting higher keV with PET, but since the half-life is very short, the patient exposure is much less with SPECT. So for those of you who are taking the board, they might give you different protocols and tell you which one has the lowest radiation. If there is one PET and the rest are SPECT, the PET is always lower than SPECT. So that is kind of like a key example. So because PET radio tracers are much lower in radiation, much shorter half-life, so even though they are 511 keV, the exposure is going to be much less for the patient. And obviously the study duration, for those of you who work on 409 versus OPC, you can tell that. If you're doing rest stress versus complete PET scan, it's very different. At this moment, until last Friday, we did not have a pharmacologic an agent where we can do stress testing with exercise for PET, but I'll tell you what changed last Friday. So at this moment, before you can do either exercise or pharm with SPECT, but with PET you can only do pharmacologic stress because of the very short half-life. So the radio tracers that have been available for us or used clinically are either rubidium, ammonia. So these were the only two that were approved for PET. As of last Friday, at like almost late in the day, FDA approved flurpiridaz. So now you have a third agent in the US approved for perfusion imaging. So that's based on F18, which has a 110-minute half-life. And then in Europe, there are some countries where O15 water is approved. So O15 water can be used in Europe. So we do not use it clinically in the US. There is an ongoing trial with O15 water to talk about that. So let's dig deeper into what's in there. So this is kind of a summary table, but there are some differences between these. And when you want to read some of these, I'll show you some of the differences and how we potentially may use them in clinical. The first one is the extraction. Remember, what I told you in nuclear compared to CT, in nuclear, we inject the patient with radioactivity, and then we want to see where it goes, and then we go to image it. So the main thing is it depends on where that radio tracer goes and how much of it is extracted from the blood. So a very important aspect is to look at what we call extraction fraction. So how much of it, how much of what I inject is extracted in the heart? Because when I inject it, that radio tracer doesn't know that I just want to go to the heart. It's going to go to the kidney, to go to the colon. Like if you look at SPECT images, where do you see most activity is happening? In the gut, right? Where you see it in the liver, in the gut. If you look at even rubidium, it's going to go in the brain. There are some research studies imaging rubidium in the brain. There are, you can image it in you can image it in the lower extremities. So there are multiple areas that it can go to. It doesn't need to go to just one area. But when we inject it, it very much depends on how much of what I inject is extracted. So these tracers that I showed you on the prior slide have different extraction fraction. Which one is the most linear? Anyone knows? That's also a cardiology board exam. It was on my cardiology board. So the O15 water. Why? Because our body is made of water. So when it is water. So that radio tracer is O15 water. So when you inject it, it just goes on the blood. It goes inside the cell, wash in, and wash out. So that's why it's just you're injecting radio-labeled water. So it's purely water, but the O, instead of being 16, if you remember your periodic table, now it's 15. So it is a different isotope of the O. So when you go and look at the radioisotope, so you inject water, its extraction is 100%. It's linear. What does that mean? So when I look at it, when a patient has stenosis, you may potentially detect reductions in blood flow even with 20, 30, 40% lesions that you may not be able to see that. Flurpiridaz, believe it or not, and that's what a lot of us have a lot of hope for, it has actually a very high extraction rate of about 0.9. So technically it's actually the second highest extraction rate. And then ammonia is better. Rubidium is actually very close to technetium. So technetium is extraction becomes what we have a roll-off phenomena. In other words, after a certain stenosis, like after a certain minor stenosis, you're not going to be able to see the differences in blood flow because of the autoregulation. And these studies were done before all of you were born, even before I was born, across the street by Dr. Lance Gould, where he showed back in the 70s that even among patients where you have early plaque, so 10, 20, 30, 40%, you're not going to be able to see drop in the blood flow when you're using some of these techniques until you reach that 70% threshold. This is where the 70% came from his early nuclear studies. And this is why we kind of rely a lot on the 70% data. So with technetium, you're probably going to miss these earlier stenosis, earlier atherosclerotic lesions, but you're only going to detect it when it becomes more stenotic because of the roll-off phenomena. But with O15 water and these more linear tracers, there is chance that you see it. So many of you get too excited sometimes that we call the small or mild defect on PET, but you did the CAT and there's only mild disease. That could happen, that you can see mild stenosis, milder stenosis, especially with higher sensitivity with PET compared to SPECT, where you tend to miss, like unless it's an artifact. And these are the extraction fractions, again, highly tested. The most highly tested is the linear one, which is O15 water, because it's just water in there. The second difference between these radio tracer is something called the positron range. What does the positron range mean? So it depends on the energy. I told you we're imaging electrons or photons, right? But we're emitting a positron. So when we emit the positron, depending on the energy of the positron, it's going to move a little bit, and then it will emit the two photons. That distance is called the positron range. So if it moves too much, what do you think the electronics is going to think? It's like this is where the annihilation line is happening. So it will say, well, this positron came from this area. And when in reality it was not this area, it was this area here. So now there are, with the new electronics, also some correction for that applied to. But that's one of the reasons why the rubidium images look a little bit fuzzier compared to FDG, because FDG or F18 has a smaller positron range. So these are the positron range of each one of them. So if you put just one dot, you can see which one has the more fuzzier image, the rubidium, and which one has the least fuzzy or the more concrete, because it has lower energy, so it doesn't move too much before it annihilates. So how does that translate to images? It translates to images, I'll show you, have some examples later on. So O15 water, for those of you taking nuclear board, it's the ideal flow tracer in the sense that it gives you highest extraction, so it gives you, it's a gold standard for assessment of flow, and it was validated against microspheres many years ago. And nowadays everything gets validated against O15 water because we know it's ideal. The only problem with it is that it's very short half-life, and since it goes inside the cell and outside the cell, you're not going to be able, it doesn't stay inside the cell to allow you to image it. So it's in the blood pool, but also in the myocardium. It's where there is water. So that's why images are very fuzzy. And now there are some AI tools and some companies that are working to create some images from these based on early uptake. So very early when it goes inside before it kind of like become uptaken in the blood pool. So there is some research work that is trying to create some of these images, but they will not look as nice as you will see on F18 agents. But for flow, the images, like you calculate flow, and that's the ideal radio tracer for you. But if you're looking for TID or a perfusion defect and others, O15 water is not going to give you these best images, although there are now some attempts to give you some sort of images that you can see where a perfusion defect is. Now, N13 ammonia is also produced by a cyclotron, so you need to, because the half-life is 10 minutes. So technically, you can produce it in the research institute and take it to the OPC. But you're not going to be able to do it and send it to the woodlands, because by the time you get there, all what you have produced have decayed and there is no more ammonia. So it has only a 9.8 minute half-life. And we inject a small dose of it. Unless you have very old system, then you need to inject higher dose. But now most centers are injecting 20 or less millicuries. And because it's a 10-minute half-life, so you can potentially theoretically do exercise. It's feasible. It has been shown in few studies, but nobody is doing it because it's clinically cumbersome and it's associated with exposure to the staff also, because once you inject the radioactivity, you still have to position the patient from their treadmill and go ahead and inject. And to be able to acquire like good images, you need to wait until the first dose decay, and then you go ahead and inject the second one. But now, with the advent of the digital systems, you can inject with low-dose, high-dose protocols, so that decay, or that delay is only needed if you have an old system. Now, there are like, these cyclotrons are like usually a big investment for any institution. So now industry has come up with there is one company that will sell you a mini cyclotron, which is probably this tall. You have a picture of it there. And this mini cyclotron will go ahead and give you ammonia, but it can give you also another radio tracer. Usually put it next door to your camera, and you just go get the dose and inject it to the patient. So if you really want to do ammonia, and you don't have a cyclotron in your institution, you can potentially work with this. And there are a few sites in the country that are using it, and they have good results, and some of them are actually high volume sites. And the only thing about ammonia is that also from an image interpretation, there are some normal nuances where you see inferolateral defect. So inferolateral defect, as you see here, some mild inferolateral defect on the top row. Yeah, so here, like you compare it, like this is the same patient who had rubidium and ammonia. You can see here at stress on top, rest on the bottom, and stress, you see this defect, even in the absence of obstructive disease. And this is one of the known artifacts from ammonia, may be related to the heart rate and the diastolic filling, but we don't know that for sure. Rubidium is what we are using right now, and usually we have a generator that you replace it every 42 days, and you just go and milk it every time and inject to the patient. So you can keep it every 7 weeks, you change it, and depending on the system you have, you can inject. You need to have higher doses for 2D systems, lower doses for 3D system, and if you have a digital PET-CT, you can inject much lower doses. And we inject it over 32 seconds. These are how the injection systems look like. This is the one we have here, and this is another system from another vendor, and you replace inside it, you get a small capsule like you see here. Where is it? Yeah, so you got this, something like this every 42 days. You open this door, put it inside, and then you're good for 42 days, as long as your QC is being done, and you can go ahead and do it. And almost right now, a large percent of what's happening in the US is rubidium PET, but there are some other ammonia sites. Will be interesting to see how the F-18 tracers are going to play. So we've been waiting for this new tracer for a long time, but believe it or not, now there are not only one tracer, there are 3 tracers. So the first one, I'll start from the least developed to the most developed. This is the one. So first of all, this is how F-18 images will look like compared to rubidium. So we have better spatial resolution with rubidium. So you can see here, even you can appreciate the papillary muscles, which you may not see very well with rubidium because of the enhanced spatial resolution. And now there is a new F-18 tracer, which is now in phase 2 from China. And there is another one from Poland, which also we're hoping to be part of phase 3 of it. And this is another F-18 tracer. But this one and this one, they just presented their accuracy data. And this you can see the data that's been presented, not published yet, with an accuracy sensitivity of 80%, specificity of 85%. And now a phase 3 trial just started, and hopefully we will be one of these sites. But the one that was just approved is flurpiridaz, and flurpiridaz actually as an F-18 agent was compared in multiple phase 1, phase 2, and 2 phase 3 trials. And they looked at it in comparison to SPECT using QCA on angiography as a gold standard. And this one actually, it acted better in terms of primary endpoint. So you can see its sensitivity by 3 readers. It's in the 70s, specificity is a little lower, and the majority rule was in the 80 for sensitivity, specificity in 64. But keep in mind that when these were interpreted by the FDA rule, they did not have the blood flow data or the calcium score data. So they only had the images and the gated. As you know, when we read PET, we don't just look at the static and gated. We look at EKG, we look at calcium score, we look at flow data, we look at multiple things. So when this result yet you see are just results of the static and gated by the FDA requirement for interpretation. So how is this gonna change? Hopefully, because you can produce it as a unit dose. So technically, let's say we want to start a PET program in Galveston, and we have a camera there, but I don't have many patients there that I want to, like, let's say I don't have 15 patients every day, so I can buy a generator. I can potentially just call this company, hopefully when it becomes available, like clinically, it's now FDA approved. I tell them, send me 1 dose or 2 doses on Wednesday at 2 p.m. If that works for them, you bring 2 patients, you inject them, and you're done. So you don't need to commit to a high volume. So for example, if we want to do 1 day in Pearland, 1 day in our satellites, or as you know, PET is not widely available. So if you want to do it in a smaller center, then you might be able to achieve this smaller volume ones. The other thing is, because it's a longer half-life, now you can do exercise. So right now we are not able to do exercise, but I can now exercise the patient on the treadmill and then inject the tracer, wait a little bit, and then image them. So if exercise is extremely important, then you can potentially do exercise. Now we're working on protocols where we can get both exercise and blood flow data. Right now it's a little bit challenging to do that, because to be able to get blood flow data, you have to exercise them and inject while they're being exercised. So we have to image them at the same time, which is right now not that feasible. So there are still a lot of work to optimize the protocols otherwise, but it looks like we have now a tracer which maybe hopefully allow us to expand on the utilization of PET, and this is the announcement from FDA on Friday that this is now being approved, and hopefully it will be clinically available in this quarter, and we'll see some of these cases. So these are the tracers and the machine. Now we're going to finish up with the applications. What do we do with PET? Any questions here? All right, put you all to sleep. All right, so what do we do with PET? So many things we can do with PET. So although many of you think that we might be just doing MPI, but PET applications are beyond MPI. MPI is still going to be the biggest one, but we can do also viability imaging. We can do inflammation imaging, or what everybody refers to as sarcoidosis, but it can be inflammation anywhere. We can, in fact, image endocarditis, or we can do infection and like anywhere else in the body. So here are some of these. I'm going to talk just very briefly, because many of these topics will have dedicated lectures during the year, which are more multimodality. So how does it fit when you want to do inflammation in addition to exercise and in addition to MRI and other modalities. So I'm just going to cover quickly for MPI. These are the patients that we usually target. The main one are the ones who had prior suboptimal or equivocal tests. We always try to target also those who have obesity or high BMI, those who would work up for new heart failure, prior cardiac transplant, young patients if we don't want to give them radiation, and obviously if they have very high atherosclerotic burden. As you know, as patients get more obese, we are able to continue to get diagnostic imaging with PET, even compared to SPECT and other modalities. So with PET, for example, our record BMI here is 76. So we haven't gone above that, but we have about 400 patients with a BMI above 50. So you can see what type of difficult patients that you may still be able to get diagnostic imaging. So perfusion imaging, I know many of you are exposed to it already clinically, or have seen it, or either ordered the tests or seen the results, or rotated and interpreted. Sometimes we combine that with viability imaging, so we can look at the areas of perfusion defect, as you see here, and try to look, like here, what you see, there is uptake in that area of perfusion defect, which indicate at least partial viability in this patient. And here, zoomed in image, where you see a very dense fixed defect, But when you do FTG imaging for viability protocol, you're able to see the viability that it is fully viable. And you can see here, for example, on stress there is a defect, on rest there is a defect, but we did viability that there is actually good amount of uptake in that area, indicating that these patients have hibernating myocardium in that area. So how is PET in the community right now? This is our most recent data that we looked at it, and PET is now, in terms of assessment of CAD, is growing, and it's one of the fastest growing alongside CT and MRI. But what you can see here, SPECT is on the decline, but we've seen some decline. Still the number one modality, but for various reasons its utilization have declined. But you can see PET is significantly increased, and CT and MRI are increased, but they are on a different scale in the Medicare population. We can also use PET for inflammation, and inflammation can be anything. So it's not only sarcoid. I know we always talk sarcoid. But when you refer patients to us, we cannot tell you if they have a caseating or non-caseating granuloma. So we're imaging primarily macrophages. So we can look at inflammation in the heart, but this can be from sarcoid, but can be from any other connective tissue disease. We've seen it with Wagner, IgG4. We've seen it with other, like rheumatoid arthritis, SLE, many other cardiomyopathies, and even some genetic cardiomyopathies may have some mild FTG uptake in there. We've also seen it in pericarditis. This is one patient who has significant FTG uptake in the pericardium. We have an MRI that shows a significant late gadolinium enhancement uptake. This is a patient where you see FTG uptake in the aorta with aortitis, and you can see this patient came in multiple times with actually ischemia because their coronary ostia is becoming so inflamed and stenosed. And you can see the amount of inflammation that we see here, and it helps because on anatomic imaging, you're not going to be able to be so sure whether this inflammation is active or not unless you do for this. You see thickened wall, you see calcification, but you cannot tell for sure the activity. Endocarditis, I'm sure many of the first years and second years had cases where different modalities either said we don't know what is going on, there might be some thickening, there is this and that, and then a PET scan kind of showed what's happening. We had few of these cases recently, and you can see here, for example, on this CT, there is this area of hypoattenuation next to metallic valve, and this area was very hot, as you see there, and this is actually an abscess on this patient, which was proven by surgery in this patient. We can also look for infection in devices. We can look at infections in leads. We can also look in LVADs. So I know many of you are on heart failure, you order these. This is like one of the worst cases where an entire outflow cannula is positive. There is not much around the device itself, but the entire outflow cannula has a lot of inflammation. So during the year, we will cover each one in a 1 hour kind of topic, along other imaging modalities for endocarditis, viability, inflammation, and others, and we will dig deeper into these. With this, I'm going to stop and happy to take questions if you are still awake. Got what you want? Yes.
So when we do PET for different late diagnosing infection like endocarditis, and so like how do we differentiate between tissues? Like
Between what?
Like when we do normal PET for our cardiac tissue and when we do specifically for endocarditis, is there any change?
So there should be a different. We use different tracer, obviously, and we have also to prepare the patient differently. So the myocardium itself doesn't uptake the glucose, and then when we do this labeled glucose, it goes only to the inflammatory cells. So we're only imaging the white blood cells that are sitting around in the area of infection. All right. Thank you.